I'm Dr. Alana Yurkiewicz, and this is Hard Medicine. What is longevity medicine, and how is it different from good primary care? That's the first question I asked my guest today, Dr. Hilary Lynn, a longevity physician and entrepreneur. Isn't helping people live longer, better quality lives what we're all trying to do? Her perspective is that longevity medicine is good preventive medicine without the financial constraints of population-based care. In other words, what makes sense for the population, because we're necessarily weighing factors like access, public health impact, and cost, may be suboptimal for an individual. Of course, we live in the real world. We need population guidelines. But strip that away for a moment. Just the medicine. What test should you get to prevent cardiovascular disease, the number one killer? To act early on insulin resistance? When should you initiate medications, and what lifestyle changes actually work? Longevity medicine as a term is unfortunately packaged with snake oil and hype. There is a lot of grift out there. The purpose of this episode is not to debunk every claim. If I don't ask about something, it's because I don't believe there's good evidence for it. It's also important to acknowledge what's in and out of our control. I've practiced medicine long enough to know how one can do everything right and get cancer or heart disease or early onset dementia. Dr. Hilary Lynn calls these black swans. I call it bad luck. This is a conversation that recognizes that fact while preserving our agency to strive for better individual health. This is a conversation about the real parts of longevity medicine that work or have emerging evidence to work. Dr. Hilary Lynn, welcome to Hard Medicine.
Thank you for having me, Dr. Ilana Yurkiewicz.
It's so good to see you again.
It is.
So as a bit of background, we did residency together. So we go way back. I'm not going to say how long because that dates both of us. But I thought you'd be the perfect guest for this episode because there's a lot of misinformation out there about longevity medicine, and I think it's very difficult to separate the wheat from the chaff. We did residency together, like I said. I know for a fact you're a good doctor. You're not crazy.
Thank you. Thank you.
Yes.
We all learned the same things. And to your point, it's a winding journey. Honestly, I have changed my mind countless times throughout learning more about longevity. Longevity is an evolving term too. So I think the field is nascent. Our understanding of it is nascent, but I think common to our origins is that I remain a highly evidence-based practicing physician.
And I completely appreciate that. So let's start with definitions. How would you define longevity medicine? And to me, it's helping people live longer, healthier lives, which is what medicine does and what primary care does. How is longevity medicine different from good primary care?
Honestly, longevity medicine should be good medicine, just practiced earlier, more proactively. And I think the biggest difference and the reason why you see a difference between real life primary care, no matter how good it is, and longevity medicine is that we are constrained by reimbursement and payment models in real life sort of primary care clinics versus longevity tends to be cash pay. There's much less regard about a cost benefit ratio. So if, for example, I'm just going to jump right into the fire, whole body MRI, very controversial because you end up spending a ton of money, possible follow-up, a lot of potential anxiety. It's obviously the wrong answer in a population-based primary care setting. However, if you're looking at the longevity population, it's a totally different question and risk benefit ratio. If money is literally not the concern and you've got all the resources to, do proper navigation, proper second opinion, proper follow-up, then it starts to make sense in a way.
Let's talk about health span versus lifespan. Can you define the two terms and what are you trying to optimize for your patients?
Luckily, they sound exactly what they mean. So lifespan is how many years, how much time you are alive. Health span is this newer-ish concept where we're describing the span of lifetime that you are healthy. And that is really subjective. Someone can consider themselves still healthy if they have, maybe a few chronic illnesses. They have hypertension, maybe they've had cancer and they've, survived it, or so forth. So there's a lot of variations of what is healthy, but I think most of us understand it as you're able to do the things you want to do in life and you aren't limited by health conditions.
First topic I want to jump into is cardiovascular health because that is the number one killer of Americans. It has remained the number one killer for a very, very long time. And there have been changes in the American Heart Association guidelines on how to think about prevention and cholesterol. And this is a very, very hot topic. So I just want to dive right into cardiovascular risk. Let's talk about cholesterol. Typically, I would say you go see your primary care doctor, maybe you're a 45-year-old, and what they will order to help you understand your risk of heart disease is a lipid panel, a fasting lipid panel in the blood. And that's mostly the extent when they go see a doctor. And there's been a lot of conversation recently about how that test alone gives you valuable information, but it's inadequate. What do you do if you see, let's say, a healthy 45-year-old who wants to understand their risk of cardiovascular disease better?
I love this topic, and it's actually one of my listeners' favorite topics. No matter how many videos I post about lipids and heart disease, I think they get gobbled up because it's such an
Yeah.
important topic. So, first of all, you're right. Most lab panels, I should say, in primary clinic are missing some important labs. So, recently, actually, everyone's come on board to accepting and including ApoB, which is a lovely
Mhm.
development because, ApoB, for people who are not familiar with this term, counts all of the atherogenic particles. There's a lot of other things that you could get, like particle number, the particle size. So, very briefly, if you have a smaller particle size, that's worse because they tend to cause worse plaque, they cause more damage, etc. And then the bigger particles are somewhat less harmful. I describe it sometimes like you're on a freeway and there's traffic, and you might have the same amount of cholesterol on the freeway in that, like, let's call it like boxes, shipping boxes. There's the same number of shipping boxes, but they can be contained in either big trucks or on little motorbikes. And what is more dangerous for traffic accidents is having a ton of motorbikes carrying the same number of boxes as like maybe two or three big trucks. If you've got the ApoB, that's probably the single most valuable number, even without all of the other fancy stuff that you could order on an advanced lipid panel.
Let's say you see a patient, you get an ApoB, you get the standard lipid panel, right? Because you're still getting a standard lipid panel, and there's a discrepancy. Their LDL, which is the quote unquote bad cholesterol, looks great. The ApoB looks terrible. How do you think about that?
I would pay closer attention to the ApoB because your standard panel is not going to pick up certain things like the LP little a, which is a very genetically defined number. So LP little a is a highly atherogenic or harmful, unhealthy type of lipid particle. And it's not collected in that standard lipid panel that we were talking about that most primary care doctors will collect. You have to order it separately or it's included with advanced lipid panels. I think it's so important because there's no correlation between your LP little a number and how healthy you live. Like your lifestyle and LP little a will not have any reasonable rhyme or reason correlation or anything like that. It's because it's defined purely through genetics. And unfortunately, there's also very little you can do about that specific risk factor with your lifestyle. Some current day medications can lower it a touch, but not significantly enough. That aside, it's important to collect that number and understand that number just because it offers like a separate risk factor. And the ApoB, luckily, will collect information about that number even without telling you the exact result.
The American Heart Association has recently updated its guidelines to include a lot of what you're saying. They do recommend now checking a lipoprotein A or LP little a one time in somebody's lifetime because, like you said, it's genetically determined. It's not anticipated to significantly change over the course of somebody's lifetime, and to include ApoB as part of a test. Are you seeing this more in practice, or do you feel like this is still something that most primary care physicians are not ordering?
I tend to see, unfortunately, that people still aren't ordering it, and it's a problem across all of care in general, healthcare in general. The reason I think this is happening is it's really hard to change default practices at a longstanding clinic. It's a great thing when doctors update their knowledge and change their practice. And, more and more knowledge is moving yet faster. So people have to like continuously educate themselves. And the reality is, most busy clinicians who have like sometimes like 50 patients a day, they're not going to have enough time to be reading all of the latest research. So unfortunately, in practice, I mostly see people who have never had these numbers checked before, unless they went out of the way to get it through some consumer testing site.
So, just before we move on to imaging for cardiovascular risk, the blood tests, your panel that you order includes a lipid panel. So, that is all the standard stuff that primary care typically orders: the LDL, the bad cholesterol, the HDL, the good cholesterol, triglycerides, plus a separate test called the ApoB, plus a separate test called the lipoprotein A. Am I missing anything?
There's also the particle numbers and size. So again, those are a little bit secondary. Like I don't rely on them all the time because if you do it enough times, you're going to realize that everybody has like an abnormal
Yeah.
particle
Yeah.
distribution. So it's more just added information. I like to see it going towards the right direction.
Yeah, exactly. I think one point that you've made is that each piece doesn't determine whether to initiate treatment like a statin. It's just giving you a fuller picture of somebody's risk that you don't get just from the standard lipid panel.
Yeah. And you talked about this in the beginning, but just to bring it back up again, there's a lot of contextual labs and health features that also matter that aren't directly your lipid panel. For example, inflammation, at least checking high sensitivity CRP. And for the metabolic health, of course, like the A1C, or I prefer a fasting insulin.
We're going to talk about that, the
Oh,
difference.
wonderful.
Yeah.
We're going to dive into it.
Does insurance typically cover these extra tests?
Yeah, so actually, what's been really interesting to me is yes, they tend to. So there's little things that tend not to get insurance coverage, or there's pushback because certain states have different laws or regulations around what can be tested. New York is one of the fun states. I'm pretty sure it's New York, New Jersey, and Rhode Island that have fun laws around labs, and some of them are regarding whether a lab is functional and whether that can be ordered, reimbursed, so forth. So there's all these like tricky little regulatory things that happen across state borders. But roughly speaking, yes, insurance does typically cover even the expanded advanced lipid panel. There's little related labs like homocysteine.
One more question before we get to imaging. Do you risk stratify your patients, or are these tests that you order pretty much on anyone who walks through the door, regardless of family history, their lifestyle, whether they have a healthy diet, exercise, etc.?
It's so easy that I screen everyone. And I won't repeat it necessarily for someone who's like totally risk-free. Say there's no one who's risk-free. This is the reason why it's like the number one killer. But a lot of people have less risk than others, or their numbers look so good and they're relatively healthy in their lifestyle. So those people, maybe I'll just check like the ApoB next time. The folks who have starkly abnormal panels, I want to follow them a lot more closely. Usually we're initiating intervention, so I want to track what's going on.
All right, so let's talk about imaging. I think it's worth distinguishing two things here: the
Okay.
coronary calcium scan versus a coronary CT angiography, or CCTA. The first, this is a test that I order frequently. It's a coronary calcium CT scan, and it helps look for plaque buildup of these hard plaques in the coronary vessels that we know increase the risk of myocardial infarction or heart attack. When are you ordering coronary calcium CT scans?
They're both CTs, so that's why you've got a very confusing terminology around them. So the CAC score is a more limited CT because they're just taking a quick picture. It can tell you what is called your coronary calcium score. And that is helpful as a basic screen because it tells you if you've got hardened plaque already in that heart area. And that's obviously important. The problem with that is that most problems come from soft plaque. So your hard plaque is actually already stable. It's less likely to rupture, clog up some arteries, cause a heart attack or stroke. It's still good information to know because you want to know if you've got that hard plaque. And then another benefit is it's relatively cheap. It's like $100 or less in most places, even if you paid out of pocket. That being said, I think it can be almost like a false reassurance because they might see a CAC score of 0 and be like, oh, I'm totally fine. But the problem is you might still have soft plaque, and you that plus like a family history or other risk factors could mean that you're, going to develop worse problems down the road. And when you turn on the longevity lens, you want to take action as early as possible before disease has the time to progress.
I order those frequently because I often can get insurance approval. I typically use them as a tiebreaker when somebody is debating, should we start a statin now or should we continue with lifestyle changes? When I use it that way and someone has an elevated marker, I typically do get insurance approval. But like you said, even out of pocket, I believe here it's a little more like $350 or $300, but it still can be doable. And just to clarify for the audience, it gives you a score, and 0 is the best you can get. So 0 means they don't visually see any hard plaques, but it's still missing the soft plaques. So in those cases, you would order a CCTA, which is the other imaging that you referenced that is more expensive.
Yes, the truth is, I order them when the patient is able to pay for them. And that's a sad reality, which is that for this preventative situation, it's typically not covered by insurance reimbursement. So it's going to be about $1,800. If it were up to me, I would get it just like I do with the labs on basically everyone, at least, at the start of evaluation. And then depending on risk, I may or may not repeat it at certain intervals. And I'm going to go even farther as to say, I wish this was the first screening that was available and affordable for everyone, because it's the only thing that actually tells you any real information about what's going on. A lab panel, like even an advanced lipid panel, they only give you risk clues as to whether somebody might develop atherosclerosis and heart disease down the line. But when you actually take a picture with a CTCA, especially with now all the great AI layers that you put on top, then that you're getting real information about what's happening. I'll even just use myself as an example. So when I first found out I had a really high ApoB, it was a total shocker because, I'm relatively healthy. I've never been overweight, that sort of a thing. And yet, in retrospect, it made sense because I have a pretty strong history. So there's probably a very strong genetic factor. And so I got myself on treatment, but I was like so worried because my ApoB had come back so high. So I got a CTCA with the AI synthesis on top, and my score came back 0, which is like perfect. And I was so relieved because I was like, oh my gosh, like I was thinking in my head that I've been walking around with all of these high lipids and there's damage. And the reality is the numbers on your blood panel are only a clue. And you can be the total opposite. You can have really good numbers on your blood test and you could have damage already. I've seen 1 or 2 cases like that as well.
What age are you starting screening?
I think the 30s is a solid time to start screening. Not that it doesn't matter before. For some people, especially with high risk factors like a really strong family history, familial hypercholesterolemia, for example, you might even want to start earlier. I think there's pediatricians who try to screen kids. I don't know if you're going to do CTs on kids, not my purview, but you do want to start screening quite early if there's a strong family history. But I think for the general public, a reasonable time to start checking is in the 30s.
Are you doing these tests on people who already have symptoms of coronary artery disease, like angina, or are these for asymptomatic patients?
This is asymptomatic screening, and we often call heart disease or atherosclerotic heart disease the silent killer because you don't typically get symptoms until quite late in the disease process. So you definitely don't want to wait for anything remotely seeming like a heart-related symptom to get screening.
So then let's talk about treatment.
Mhm.
So we will talk about diet and exercise and the nuances there. Right now, I'm just going to bucket them as diet and exercise versus pharmacologic treatment. And
Yeah.
typically the pharmacologic treatment is statins as first line. There are many other options now, and we can get into it a little bit, but when are you thinking about starting pharmacologic treatment on your patients?
I actually am fairly aggressive fairly early. And the reason I am
Me
is
too.
because, yeah, I know. A lot of people are very scared of statins these days because there's all this social media stuff. And just to name it out loud, what people are coming to me afraid of is they're afraid that they're damaging their muscles. And that's like a very rare, very, very rare sort of situation. They're afraid of side effects. Those are real. I've actually had statin related side effects. And some people are afraid that it's like killing off their mitochondria, which is like an overblown assumption or, mechanism. But statins are just one tool in the giant toolbox of lipid altering medications. So we're very lucky now, I think. We can essentially, if you catch atherosclerotic disease early enough, you can essentially prevent a heart attack or an ischemic heart attack, just to be precise, or a stroke from happening, basically, with almost 100%, because we have such good drugs. And we're not even talking about the drugs that are around the corner. So I start pretty early because the medications are relatively harm-free or less compared to the potential result of plaque development.
Statins really work. There is a small but real risk of side effects. The nice thing about statins is that there's a lot on the market. And so sometimes just switching to a lower dose or switching to a different statin, but it's still a statin medication, like you switch from atorvastatin to pravastatin or a rosuvastatin, can reduce these side effects in people.
That is definitely one option. And then another freebie that I also on, we don't talk about it at all, I feel like in med school or training, but ezetimibe.
Oh,
It's
I
because
love
it,
it. I love
yeah,
Zydia.
it's such a good medication. Yes, by itself, it doesn't do very much, but it's like a good adjunct to
Yeah.
anything else. Essentially, no side effects for vast majority of people. And then PCSK9
Yeah.
inhibitors, such a like basically miracle drug. And they're like,
And
if people
these are injectables.
injectables, yes. Although they're coming out with all sorts of PCSK9 treatments, including epigenetic and gene therapies coming around the corner in the
Yeah.
next few years. So that's wild to me because you can have a semi-permanent or permanent solution essentially.
We're going to talk about lifestyle changes in addition, in conjunction with
Mhm.
pharmacologics that people can take. But before we do, let us go back to the A1C and the insulin resistance question. This is something that comes up a lot too about what tests we should be ordering as screening for people. So, again, just going back to kind of your typical primary care visit, what a primary care physician is going to get is something called the hemoglobin A1C, which the way I explain it to patients is that it looks at what your blood sugars have been doing over the last 3 months, as well as usually, I would say, a fasting glucose. Do you think that's sufficient?
Those are sufficient, but I love to get also the fasting insulin. And there's a couple of reasons why. One is it is more sensitive to changes in your metabolic health. Your fasting insulin is going to go up or down faster to changes in your insulin sensitivity. And if you get it, you can also calculate, the HOMA IR, which is a fun but studied number that can help you understand how insulin sensitive and insulin resistant you are. And I have seen so many times actually now that the A1C just like kind of like wiggles up and down and has like, yes, in broad strokes, it will correlate with your metabolic health and it's so useful at a population level. But again, like I'm working with people to optimize health and it's just not good enough. I think there's too much variability because it's dependent on our red blood cells, their lifespan and so forth. So the number is just not super specific. So I find it's a lot more useful to just get all of the above and then trend that more.
Is fasting insulin something that insurance covers?
Yeah, typically it is.
The other thing that a lot of people are doing is looking for continuous glucose monitors or CGMs, sometimes paying out of pocket for those. And, some of my patients who are just really more into the longevity space describe it as they just want more information about what foods in particular will spike them, right? Like it's seeing if you eat a certain carb, maybe your glucose is going to go way high. You eat a different carb, your glucose is not going to go as high. It just gives them more information to then tailor their diet in a way that keeps their glucose levels in check. What do you think about CGMs let's say you do all of this screening for an asymptomatic person and it's all beautiful and normal. Should
Yeah.
they be also getting a CGM?
I think of CGMs as an engagement tool, is how I think about it. It's the same way I think about like an Aura ring or an Apple Watch. And what I mean by that is it can be good or bad depending on your situation. And you have to kind of understand its limitations. So I have tried, both of the main CGMs out there. There's two companies that have them. And there's flaws with both of them. Like there's inaccuracies, or sometimes it's like with the app, the just like simple ways that they portray numbers or smooth them out can be kind of confusing. That being said, I agree with the general premise that if you do like a 2 week trial or a few 2 week trials, you could do really good experiments on foods that tend to spike you more. I definitely learned a lot about myself. Some people say, and actually, Mike Snyder, who's a genetics researcher who does a lot of stuff on this at Stanford, he's like gotten deep into like the types of diabetes, and there's like very different kind of idiosyncratic characteristics that you can determine only with the use of CGM. But for real life usage, I would say it's a very useful thing. It can tell you if like potatoes spike you more, rice spikes you more, or if you're like me and everything that you think might spike you definitely does. And so, but like, and you can also see over time, like I made changes from like exercise to diet to some of my medications. And like you can see in a very satisfactory manner that things tend to not spike as much. And you're like, oh, wow, like what I'm doing is actually working.
Yeah, I think what people have seen on the CGMs too, which is helpful, is that I mean what we've always known, but seeing it can help is that exercising after meals, even a 5, 10, 15-minute walk can blunt the increase that the
Yeah.
sugar load is going to give you.
Yeah, or doing squats. I once I was at a friend's dinner group and we had Chinese takeout basically. But I was like already starting to avoid like rice and especially carby things. But even so, in the sauces and things like that, you don't think about it. There's a lot of sugar. I remember looking at my CGM numbers. I'm like, oh my God, it went up so high. And then, I just started doing squats. I had to do like 200 squats.
And I like what you said. I think it's for the right patient and the right circumstances. For some people, it really is information overload. It will ding you. It will make a noise if your sugar goes too
Yeah.
high, even if your sugar goes too high for like 2 seconds, right? But then it comes back down. It updates every 5 minutes or so, and that can be just a lot.
I encourage people to do it intermittently. You don't need to remind yourself all the time.
So, kind of analogous to the statin question, but for insulin resistance, when do you intervene with medications like metformin?
Mhm. I have a new tool in my toolkit that I use, and that's a carbose. That's a drug that we don't talk a lot about in the US system because it's only like a medium useful diabetes drug. You take it with your food. Long story short, it makes it so your body doesn't absorb the faster sugars like glucose and so forth. Early in your digestive tract, and then instead it maintains it as like a more complex carb essentially down your gut. So it's almost like this is oversimplifying it. It's almost like turning it to a fiber-like substance. So the reason I bring that up is the only main side effect is like fiber, it can create like a fullness sensation and bloating. So it's like uncomfortable and people don't love it, but it's like otherwise extremely safe and extremely effective. I've seen it on people's numbers. Metformin has also GI side effects in some folks, but if people are interested, I will offer that up like fairly early as well. I'm not waiting for those pre-diabetes numbers that a lot of people are looking for in traditional primary care medicine. I believe that for most patients, you always want to evaluate everyone, individually. These types of drugs are so low risk that you can start them very early, almost in this preventative manner. When it gets to things like GLP-1s, which are actually incredibly useful and very powerful, it's so powerful, though, that it's a different equation.
I wasn't going to get into too much detail with GLP-1s. I do prescribe them very often. I prescribe them when they're indicated for obesity, for people who already have diabetes, who have significant comorbidities in addition to obesity. You talked about GLP-1 microdosing. Is that something you recommend? And tell me who you would
Oh,
recommend.
yeah. I want to, set the stage a little bit because this becomes such a big controversial topic. And I have tried to approach it with, first principles sort of thinking, which is that there's a billion studies now on GLP-1s, even the latest, newest ones. And we generally understand that they have massive positive effects on multiple systems. Likely, it's mostly metabolic and mostly anti-inflammatory sort of positive effects, causing all of the other positive effects. But those are incidentally the two major systems that are awry in modern living. So I think for a lot of people who live a modern lifestyle, it's incredibly helpful. And that's why I sort of think it as like the first mainstream longevity medication. That being said, I don't start everyone on a GLP-1, far from it. Again, to use myself, since I can share. I've tried a low dose of GLP-1s with some side effects I didn't like. It actually affected my mood, which is something you read about in the studies, but see somewhat less often. But in other folks who are okay with the side effect profile, like they don't feel too bad on it, I have mostly seen positives across the board. So, of course, folks who have the excess weight, especially visceral fat, like we worry a lot about that because that's like a very active depot of fat that can cause illness and aging and problems in the rest of your body. I'm a very slow and low doser in that, I think the old way or the standard way probably I say it's the old way because it's an old way for me, but a lot of people still do this of just going up and up and up on the dose like each month to maximize weight loss. I feel like that's the wrong idea because yes, it will be effective for that fast weight loss, but now we have longer term studies showing that people almost to the month, you can see like the 18-month turnaround, people will like yo-yo right back up when they come off. So I'm not really thinking about weight when I'm treating a person with a GLP-1. I'm thinking about their metabolic and overall health, their inflammatory health.
I do want to talk about lifestyle. This is probably the biggest question that I get in primary care. Kind of broadly, the way I would bucket for people is exercise, diet, sleep, and social connections and kind of stress, more mental health. But I think one place where people are often surprised is that I put exercise above diet. Living a sedentary lifestyle we know is not good for you. Do you agree with my buckets? Is there anything else that you would put in there?
I agree with the buckets. There's like a sort of side bucket I call, which is like avoiding harmful things, avoiding risks. And that's for like alcohol, smoking, not wearing your seatbelt. But yeah, generally speaking, I agree with you. The order of it is super complicated. Like it's hard for me to choose a priority order. I understand and agree with you. Exercise above nutrition, only in that it's a bigger needle mover. The only a caveat I would say is that you can make one really big change to your nutrition that will make a difference, which is to not overeat or like to overeat calories specifically. You can eat lots and lots of lettuce, for example, but when you
Sounds like a
have
great lifestyle. I can't
I
wait
know.
to.
Yeah. So, yeah, because if you are overdoing it in caloric density, then it's not directly, we're not talking about just weight in longevity and healthcare, but you can't exercise that away. All of that excess fat, it builds up, it causes problems for the rest of your body. I often actually try to bring sleep up earlier because it's such a ignored one for a
Yeah,
lot of people. Now
agreed.
people are trying, yeah, people are getting more into it, like they're biohacking their sleep. But yeah, without good sleep, you're not going to recover well. Your exercise is not going to be as effective.
Hmm.
You might stress your body out unnecessarily, actually, if you're trying to exercise hard and not recovering well. So sleep, I would say, if you can alter it in any way, a lot of people have a lot of extenuating circumstances, is what I've learned. It's the number one thing to try and protect.
Back to exercise. Let's say again, you have this relatively healthy 45-year-old come to see you in the office, and they just ask you, Dr. Lynn, what kind of exercise should I be shooting for?
Well, it depends on where you're starting, and it's a different answer for every single person because I have met people who have never formally exercised a day in their life, and I was like you not long ago. So for that person, it's really just like getting started. If you just go to the gym 3 times a week and just promise to stand there for at least 5 minutes, then you will progress. And then there's the folks who are already exercising and they're like, I want to optimize, what types of exercise I'm doing and for how long and so forth. In those cases, then I get into the details. I'm like, okay, you want to emphasize resistance training. If we're talking about longevity optimization, resistance training is very helpful. It helps you build up muscle strength. It's your functional strength and agility is also very important for longevity. And then also cardiovascular training is also important, but people kind of do it in an inefficient way. This is not for marathon training. This is for, longevity, so-called training. If you are looking for the most efficient way to do it, then you have like limited interval type exercise, like where you're doing like high and then recovery low, alternating like a hit exercise, but not for even that long, like for 10 minutes at a time. So you're not overtaxing your neurologic system. So you need both. You need the cardio, you need the resistance training. In terms of time spent in gym, if that's where you're doing it, then more of that time is actually probably going to be spent doing resistance exercise.
The classic teaching in primary care in terms of time spent, aiming for 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity exercise per week. So that's talking more about the cardio aspect of it. So moderate is something like a very brisk walk. Intense is more like the elliptical or jogging. Are those still the numbers that you use?
I don't obsess about the exact amount of time, but roughly speaking, those are good goals. And the reason why is, the truth is people are not being very exact when they're like thinking high intensity or moderate intensity. But if you think 150 minutes, I mostly aim for that, by the way. And the reason is because when you anchor on just the high intensity stuff, you kind of forget about the moderate intensity, which is still important, even if you are getting the high intensity. If you were in the ideal scenario, 80% of that would be like zone two-ish training, and the rest, the 20%, would be like this interval type training.
Resistance training. Is this the type of thing you recommend doing twice a week?
If we're getting really into the nitty-gritty, it's exercising each of your muscle groups about 2 times a week. Some people with extremely great recovery, they might fit in like 3 times a week. So, just to give a broad example, if you're doing your legs, you're doing 2 leg workouts a week or 2 upper body workouts a week, or if you divide it a different way, you just like count the muscle groups.
Let's go back to diet. So, I mean, there's been, oh my God, so much research on diet over the years. And I think it still comes down to me that what I recommend and what I often say to patients is that the Mediterranean diet is
I
really
know,
one of
right?
the few diets, yeah, that has been shown to improve mortality and decrease morbidity. In broad strokes, what kind of diet are you recommending to patients?
Yeah. So the reason, and I too share your frustration that I sense, which is that nutrition science is so imperfect. And Mediterranean diet comes up a lot because it's just our default diet for unprocessed food diet. So it's like it could probably be,
Exactly.
yeah, it
There
could
could
just
be
be
different
like
components of the Mediterranean diet that probably would be shown to be as effective that we just haven't
exactly. We
studied.
could call it like a Californian diet or whatever. Like it's like, but you kind of get the general idea. It's like relatively unprocessed meals
Stuff that
and
comes from the ground, stuff that comes from
yes.
trees, stuff that comes from animals are okay. Yeah.
Yes,
Okay.
yes. And actually something that confuses people is it's I have to look into the exact definition of what people are calling the Mediterranean diet, but it's the healthy diet that I would recommend is probably much lower carb. So some people think like Mediterranean, like Italy, and then they think pasta. And I'm like, and then I have to get into this whole thing where I'm like, well, pasta was like a fairly American trend. More important thing, I think, is to focus on the nutrients, so macronutrients and micronutrients. And without going crazy into all the nitty-gritty details, roughly speaking, for macronutrients, I mainly tell people focus on your protein and your fiber. If you get enough protein and you get enough fiber every single day, you're already doing 90% of the work. And then the rest of it is decreasing the calories overall. I'm saying that because most people overeat calories. Like
Yeah.
obviously some people are going to need more calories for whatever reason. And then that usually comes from fat and carbs, the other macros. The biggest thing I will say, because people will like turn this into like, oh, are you saying like everyone should be on a low carb or low fat? That's like way too broad of a over assumption. Fats and carbs are both important, and different people with different lifestyles. Like if you're a runner, you're going to need more carbs. But the catches I often see, or like the things that trip people up, are fats are extremely calorific. Like you've got 9 calories per gram kind of a thing rather than four, which is the case for protein and carbs. So it's really easy to overdo calories if you're eating like nuts. People are so nuts about nuts. They think they think it's like really healthy,
Yeah.
and generally yes, but like a few. You could eat like 5 to 10 cashews roasted cashews at a time, and then it starts like really adding up. And then the carbs, the truth is carbs can be healthy, and I eat carbs, but most people way overeat carbs. So I think that's just modern life. Modern life and modern diets, restaurants, they anchor on really high carb foods because it's a cheaper food material. It's going to be rice, it's going to be pasta, it's going to be breads, simply because it fills you up with cheaper food material.
And how much stock do you put into the timing of eating like intermittent fasting versus just pure number of calories you get in a day?
Pure number of calories is far more important for sure.
Yeah.
And for the intermittent fasting, the research seems to like update every day, but the general research synthesis today seems to be that intermittent fasting is good for gut rest, because if you're constantly feeding your gut, it's not recovering. It's like the rest of your body; it needs time to recover. It impacts your sleep. People talk about that more now. If you're eating far too late, you'll have lower quality, lower restorative sleep. But the intermittent fasting is mainly helping you because it's cutting the amount of time that you're eating. So therefore, it's sometimes helpful for people to cut down on calories.
Let's talk about the sleep bucket a little bit more. There's sleep onset, there's sleep latency. So basically, you want to be able to get to sleep in a reasonable amount of time, but you also want to be able to stay asleep and have high quality, good REM sleep. Any general advice for sleep that you're telling people of what you should be aiming for? Again, this is like Dr. Lynn, this is what I do. I sleep probably 7.5 hours a night. Maybe I wake up once, I use the bathroom. Is that good quality sleep? Should I be aiming for more?
The most basic test you could do on your sleep is, do you feel well energized through the day? Generally speaking, do you wake up feeling refreshed and then do you stay pretty refreshed until the evening? If so, you're probably getting good enough quality of sleep that, over optimizing it is probably just going to make you really stressed. Other than that, aiming for about that 7 to 9 hours of sleep is a general sweet spot. People have sort of slight differences in the amount and quality and interruptions to their sleep. Very few people are genetic short sleepers, needing less than that amount of time, like 5 hours. And the people who are getting more than 9 hours, a lot of times you have to take a look at what they're compensating for. So often they're sick or their sleep quality is not very good. And so their bodies stay asleep longer. There's going to be, again, exceptions to every single rule. All the stuff about optimizing sleep, like sleep hygiene, keeping it really dark, keeping it cool, these are all great, but I think there's probably too much attention like to over optimizing those types of details rather than simply like you just got to give your body the same consistent sleep and wake time and enough time to get your sleep done.
And I think another teaching point here is it is really about the big picture. Everyone's going to have a night of poor sleep every now and again, and that's okay. But this is what you should be generally aiming for.
Yeah,
Um,
yeah.
and if you don't wake up feeling refreshed, think about asking questions about sleep apnea. That is just a lesson to our listeners.
So common. And then I will say one more thing is if you do need it, say you have something going on in your life, sleep medication, the right kind, that isn't, causing you to have poor quality sleep, because there are some medicines that give you poor quality sleep versus others. They're great. Like I think of it just the same way I do about like lipids and heart disease. Like if your sleep is disordered for whatever reason that is out of your control, you can't just fix it with lifestyle.
Mhm.
Sometimes you're going to need medication.
Definitely. I mean, the number one recommendation is still doing CBT for insomnia, cognitive behavioral therapy, but it doesn't work for people, and a lot of people might need an adjunct in addition to that, and that's completely fine. If they're worried about dementia risk with some of these medications, there's also increased dementia risk with poor sleep chronically
Yeah.
over years and years and years. Getting to that fourth bucket, which is kind of big, but there have been studies about social connections, and meaning and purpose and mental health. People who basically feel like they have a meaningful life, they're surrounded by people they love, they tend to live longer. What are your thoughts about this?
It's absolutely true. And it's this is where we get into softer sciences. So we can't pin it down to like a single thing or a mechanism. I think the most scientific mechanism we can point to is that people who are connected, they have close connections, whether it's in family, partnership, friends, whomever, they're less stressed. And we know that stress reactions through the body age us, cause greater disease. And so that's like the most mechanical way of describing it. But also, like, we all feel and understand the positive benefits of having purpose and, a reason to get up and keep going. And also having people in your life that make your life worth living, make also it more worth it to have healthy habits. So, like, all the behavior changes that we're talking about, it's kind of hard work to be a healthy person. Sometimes it's a lot easier to just lie down on your couch and eat burgers and fries. So I think it's general sense of purpose will give you general sense of purpose to also improve your life in multiple ways.
Let's talk a little bit about neurodegenerative disease and prevention. So, with the big caveat here that there are many factors outside of our control. Genetics play an important role in your risk for Alzheimer's and other types of dementia. But what would you advise patients to reduce their risk of getting dementia in old age?
To your first point about the genetics, a lot of it is the same exact stuff we were talking about with the heart disease, the atherosclerotic disease. So if you treat those things, you're also going to have a better luck with atherosclerotic related dementia, which is most of them. So, other than that, though, avoiding brain trauma. So, if you are in a contact sport, wearing helmets where necessary, when you're biking, avoid concussions, and also sleeping well throughout your life as much as you can. Avoiding depression, actually, like so, we see brain changes with conditions like depression that can cause later down the road, sort of the dementia effects. And also making sure that you've got a lot of reserve. So, reserve is how much you're using your brain, like your cognitive reserve. So, the more education you've had, it tends to be correlated with less dementia, and it's related to that reserve. But also, you don't have to like go back to school. You can just keep learning throughout your life. So that's why we see people who are using their brains, like you see incredibly elderly folks who are maybe frail in all sorts of other ways, but they're so sharp. And it's some of them, not all of them, but it's because they're just constantly using their brains. And then finally, physical activity is very important. So we know that all of this exercise is not only helpful for your, not head, but also for your brain. It's incredibly helpful. And of course, avoiding smoking and avoiding isolation. Actually, I should bring that up because isolation in multiple ways can really cause dementia. So, social isolation, also, if you're deaf or have hearing issues, we know that that increases your risk and development of decline. And it's simply because your brain isn't getting stimulated in the same way.
I really like the first thing you said that I think it bears repeating is that a lot of what's good for your heart is also good for your brain health. So
Yeah.
avoiding atherosclerotic disease or treating atherosclerotic disease early is also going to help hopefully stave off dementia and decrease the dementia risk. I do want to ask about supplements.
Hmm.
There, the whole point of this podcast is we're only going to talk about things that I think actually, do have benefit and are effective and not just debunk everything out there because
Sure.
that would take many hours and is a waste of probably both of our times and all of our listeners' time. So, supplements. There's a lot of garbage out there. I think that's just worth saying. Are there supplements that you do recommend that you think are evidence-based and which ones?
There definitely are. I think, generally speaking, just to call it out, some people are so afraid of medications, but they're taking 12 supplements. That doesn't make any sense to me. I mean, supplements are just less regulated medications. That being said, I take supplements. I recommend supplements. I'll name some of the most based ones that are also the same ones that I recommend most often. So, vitamin D tends to be a deficiency that I catch more and more now. I just think we're indoors all the time. I mean, I certainly am. I think folks who have methylation genetics that warrant it, you can take B vitamins, B folate and B12 are the ones, the methylated versions. If you are deficient, and only if you're deficient minerals like iron, magnesium, interestingly, is this one's up for debate, but it's relatively harm-free. And I think most everyone feels some sort of improvement, such as for their sleep, when they take a version of magnesium. Creatine for select folks who can benefit from it, either from the cognitive side or from the muscle building side. And also, protein is a supplement. Like people forget about that because it comes in I don't know, a bottle, I guess. But protein is a supplement, and a lot of people need to rely on supplementation for protein because it's just hard to get it through Whole Foods when your goals are especially high. And then same thing for fiber. Fiber is so hard. I even try really hard to get fiber through my food, and it's really hard to get close to that 30 grams of fiber a day. So I do supplement myself as well.
My number one most prescribed or recommended supplement is vitamin D. I tend to check vitamin D in folks who either have osteopenia or osteoporosis or at significantly increased risk because they're postmenopausal, etc. And you're right, many people are vitamin D deficient. I mean, we get it through food, but we also get it through sunlight, and for good reason. You know, people they don't want skin
Yeah.
cancer, so we're not getting that's good, right? Like, so we're not getting as much direct sunlight, but it's a pretty easy one to replete, and there are other benefits beyond bone health. You're basing a lot of this on blood tests, right? Like you're repleting vitamins
Yeah.
if people are deficient. I think there's these trends now to take certain vitamins, even if all your blood tests are perfectly normal, which it's not going to benefit you.
Yeah, no, it's like really unnecessary. Take a little bit more magnesium. Your body's going to handle it pretty well unless you have kidney disease. And creatine, protein, that sort of stuff, it's not stuff that you would measure on your blood test. So, yeah, those are generally well proven, evidence-based, and more people can take them. The other ones I typically am basing on deficiencies.
Bigger picture questions. We kind of started by saying, how is this different from good primary care? Is this different from good primary care? And I really appreciate your answer that it's kind of like ideal primary care if we took away some of those other constraints, like financial constraints. However, longevity medicine practices tend to be very expensive for patients. How do you think about providing this service to the broad population?
I actually think the period of time we're living through right now, like these 5 years, are the most expensive time for longevity medicine ever. And the reason is it's still fairly manual. It's still basically done in clinical visits, one-on-one with doctors. But, without turning this into a whole different kind of conversation, I think with the a revolution that's happening with AI enablement or transformation of healthcare, we're going to start seeing, obvious democratization of all healthcare. I'm an optimist. I'm an AI optimist. So there's going to be people who disagree strongly with me, but I truly believe there's ways to get people basically all of this evidence-based intervention without, introducing the expensive aspects of it, which honestly, a lot of it is due to clinical operations. Everything in healthcare that's expensive is due to the human labor aspect of it or the introduction of insurance, like payer and people who are fighting against the payers. All of that that inefficiency is nothing really to do with the quality of the interventions themselves.
Another risk, we kind of touched upon it when we talked about insulin resistance, but this idea of just over optimizing, over testing, like getting your CGM data that's going to ping you every 5 minutes, that can, I think, really affect people's mental health in unhealthy
Totally.
ways. When we talked about the benefits of just a good, purposeful, meaningful life in longevity. So what do you think about over testing, over optimizing, kind of getting sucked in a little bit too much into trying to live a perfect life?
It's very tempting because it's like a gamified system. You're trying to chase some score or number. And I tell people that longevity medicine, the great part of it, it's a long-term game. You are what you do regularly, and that's the same thing for longevity, for health. And so I tell folks, you've got to zoom out and then also recognize that black swans or like crazy events, like accidents happen. So you don't want to be that person who ate perfectly and slept perfectly and didn't spend time with your friends because it was bad for your health, and then you get hit by a bus. You want to make sure that your life is worth living now and you're just doing your best to make it as long as possible.
I have two rapid fire questions for you, and then the final question. Anything else we should be talking about in longevity medicine that you think is really promising that we don't talk a lot about?
Vaccines.
I
So
love that answer.
it's
The
so
ultimate
yeah,
longevity medicine.
yeah. The ultimate, right? You're preventing the problem. But I'm going to go even farther because people don't think about this second part, is that there's now a lot of research about the shingles vaccine. And this is like a proof of concept where the herpes virus that's responsible for shingles lives in your body for a long time. And it turns out that if your body is fighting it constantly to control it, which is essentially what you do when you've had exposure, it actually stresses your inflammatory system and it causes inflammation. And so the theory is if you get the shingles vaccine or like for any other similar disease like this and you tamp it down, then you're helping you're helping your immune system out. And that's going to decrease aging, damage, and illness overall.
Many benefits to vaccines besides preventing the infection that it's targeting
Yes.
towards. Second rapid fire question, kind of the opposite direction. What are we talking about too much in longevity medicine that's not evidence-based?
Oh, biological age tests. I do them, but I do them with a balanced perspective. Like they are, again, an engagement tool and not just biological age tests, any single score you see, your sleep score or whatever score. I think if you go in knowing the context of how that score was gotten, essentially, or calculated, then it's great. You can use it to trend your day to day. But people literally obsess over these numbers that don't have any intrinsic meaning themselves.
So, final question, putting it all together, what
Yeah.
parts of longevity medicine are real?
Definitely earlier prevention, much more aggressive prevention, much better risk stratification, and also preserving your function.
Thank you so much for joining me on Hard Medicine. Always great to see you.
Thank you so much for having me. This has been a pleasure.
Thank you to founding member Matthew Beckman. If this conversation helped you see medicine differently, subscribe to Hard Medicine and share this episode with someone who should be part of the conversation.